Because my concern is that right now the so-called primary care, we're talking about like GPs, polyclinics, and especially the GPs, is totally not integrated at all with our secondary and tertiary care. And as you might mention, if someone's a GP and I refer, say a GP refers to a specialist in a public hospital, the patient is totally not eligible. So sometimes I wonder, and you look at the polyclinics, the long queue, the long wait, you can see how many of the elderly are flocking there. You know that obviously there's a lot of need, and the reason why they don't go to the GP is because the GPs, they're considered private, so any kind of drug which you think of that will be subsidized in the public sector will get no subsidy in a GP. So how do you propose that this can be integrated? Because I mean, we have been talking about this integration even since Kobun Wan's time, and until now I see basically very little progress in that.
I totally agree with you. There's currently a huge barrier between the private and public sector, especially in primary care. There are some attempts that are being made. There's the CHES and the CDMP, which is the Chronic Disease Management Program. The concern is that, as you rightly pointed out, the cost of drugs are one of the major costs that are affecting GPs. And one of the suggestions that was brought up was to allow GPs to participate in the GPO tender. The government has a GPO tender, which is actually a very good scheme, in that they use economies of scale, because they issue a tender for a particular drug, and that will cover the entire public sector. So the companies bid very competitively for this, and they get the drugs at a very good price. So this price is available to the polyclinics. But if the GPs are truly partners in public healthcare, then there's no reason why the GPs should not be able to buy the drugs at the GPO tender price and then be regulated in how they distribute the drugs within a certain reasonable framework. Of course, every GP is in a different location, so they have different rental costs and other issues like that. But there's a philosophical problem here, and this is the issue of trust. And the perception among many of my GP friends is that the government doesn't trust them enough. And I think that is the major concern. And that's why the SDP healthcare plan is very straightforward. See, it doesn't care whether you're public, whether you're private, it's just what kind of condition you're talking about. Chronic disease, 90% subsidy. Acute disease, you have to pay the $10 co-payment. And I think that's the way it has to be in the future. This wall, 80% of the primary healthcare in Singapore is provided by GPs. These are the people who are out there day and night. You know, when I used to play badminton with my GP friends, we play at 9:30 at night because that's when their clinics close. You know, they're working 363 days a year, but yet there is this trust gap, which is the barrier between the private and the public sector, and that's a major concern. I agree entirely with you.
So what is this trust factor?
So the trust factor is, I think the perception is that if the government were to subsidize the treatment in GP clinics, the government is afraid that the GPs will just mark up and will charge them the earth, you see. So I think that there is this trust factor which is missing amongst the funders, and that's why they're taking little baby steps with all of these CHAS schemes where there's a lot of restrictions, a lot of paperwork in there, just to try and prevent one or two GPs from trying to game the system.
I think this is where the members of the public have got, it's the right time for the members of the public to give feedback to the government. The government is collecting feedback, they're doing a revamp to the MediShield Life, and probably this preventive care could be something that could be covered by MediShield Life as well. If you look at the panel that's looking at the MediShield Life, there are no health economists there are no academics there, but still it's still a very good exercise that's happening in the sense that they're getting feedback from members of the public. So if you want, I mean, there's nothing to incentivize the primary, the GPs, you know, to right now they're just treating the symptoms. I mean, if you're a smoker, no GP will go to you and say, you're a smoker, don't you think you need to go to a smoking cessation clinic? Why don't I recommend you to go to a smoking cessation clinic? There's no there is no incentive for him to do that. There is no incentive for him to suggest that you take a blood test to see if you have diabetes or some other medical illness. How do we incentivize the GPs to do that? So this is the feedback the members of the general public can give to this panel that's reviewing the Managed Life.
May I? Okay. Yeah. I think one of the reasons why is that a lot of people have lost their trust in our public healthcare system. A lot of people who want to be in a more comfortable, higher class ward, who can afford to, don't trust the system. Why? Because the last time they asked in Parliament, what's the percentage of people who are successful, they apply for a downgrade after they go to a higher class ward? 1% success rate, 99% failure rate. Right? So if you don't trust the system, even you have the money, you'll be afraid to go to a higher class ward. So like Paul or Ravi, you know, anyway of late now, every week you will see trust us, you know, right? You keep to saying trust us, then something has to be wrong, you know. And this is translated into our public healthcare system as well.